Jennifer Furin.
Great, thank you so much, everyone. I feel like I should be giving all of you a certificate for having to listen to me speak so often in the last 2 days. But it gives me great pleasure and is a real privilege to be able to speak with you today about pediatric HIV. And I have to tell you, HIV is actually the reason that I personally went into medicine. I was a teenager when HIV first started coming around, and it's a really terrible disease. But in addition to being a terrible disease in terms of morbidity and mortality, it is such a rotten disease in that it isolates people from their communities and their loved ones. And so I've tried to dedicate my life and my career to fighting HIV along with MDR-TB, but I wanted to talk to you a little bit today about HIV in children in the Philippines. So the objectives of my lecture will be to review the epidemiology of HIV in children here and in the Philippines and then globally. The Philippines is a low-burden country when it comes to HIV, and I will tell you, again, with great admiration for the work that you guys do here, the Philippines suffers from a lot of similar problems that we see in low-burden countries, where very basic principles of HIV care that are widely implemented in countries with far fewer resources are not implemented here simply because your burden is low, and I think we can change that. I was inspired to hear Dr. Sally yesterday talking about elimination of measles, and I will tell you the Philippines is actually in a position to eliminate pediatric HIV. You guys are a country that doesn't need to see a single case of HIV in children, and we're going to talk about how to do that and why. And much like we talked about with tuberculosis yesterday and drug-resistant tuberculosis, HIV is very much a family disease. And I think if we approach it as a family disease, we'll be much more successful as opposed to just approaching it as a pediatric problem. So globally, there are more than 3 million children living with HIV today. Approximately 250,000 children are newly infected every single year, which is a rather appalling number. This number is appalling, but it represents a significant decrease in pediatric HIV. Overall rates of HIV infection are declining a little bit in most parts of the world, but in children they're dropping dramatically, and this is largely from very simple interventions being practiced. Most of the kids with HIV in the world live in sub-Saharan Africa. This is where I spend most of my time working, so I know that pandemic well. But children are really a very vulnerable population when it comes to HIV, and they face unique challenges that I hope we can highlight briefly in the talk today. You have to forgive this slide. I cut and pasted something, and I didn't cut and paste it well. So the yellow bars in this very bad graphic actually show the numbers of HIV cases in the Philippines, and you can see the numbers rising dramatically. Okay, there are 9 countries, only 9 countries in the world where rates of HIV are increasing, and the Philippines is one of those 9 countries. Between 2008 and 2012, rates of HIV in the Philippines have increased by 538%. Okay, so you guys are in the midst of a rising HIV epidemic when most of the world is seeing a decline. What this means is the traditional risk groups in who you think about HIV are no longer going to apply. You're going to be seeing a lot more HIV in adolescents, and this has in fact been reported. And I want to comment on Dr. Chris Mendoza's work that's presented on a poster out there that shows the rising rates of other sexually transmitted diseases in the adolescent population, so those are our 10 to 18-year-olds. If you see rates of syphilis going up and chlamydia and gonorrhea, as is documented here, you will also see rates of HIV going up. So I just want to mention that. There's been little work done with children in the Philippines around HIV, and I think largely because you had a limited experience with it, some basic things fall through the cracks. I'm sorry again for the micrographia. My 9-year-old nephew told me I needed to get modern, and I clearly do, because when I cut and paste tables, I'm not doing a very good job. But I pulled this off the UNAIDS website. Okay, before coming here, I wanted to prepare myself a little bit for the Philippines, and I looked up how much pediatric HIV there was in the Philippines on the UNAIDS website. And when you look at children, you know what the number says? It says not applicable. Okay, so this is the Philippines' latest global data. When you look up how many children are affected with HIV in the Philippines, it says not applicable, which is certainly not true. So these are some indicators of how well the Philippines is doing for children with HIV, both in terms of treatment and prevention. And we looked at the percentage of HIV-positive pregnant women who receive antiretrovirals to reduce mother-to-child transmission, 8%. Okay, 8%. I'm telling you, the countries I work in sub-Saharan Africa, no running water, no electricity, our rates of coverage of antiretroviral therapy for pregnant women is over 80%. Here in the Philippines, only 8% of pregnant women are offered antiretroviral therapy. Okay, there's no data available about breastfeeding. Okay, of infants who are born to HIV-positive women, how many of them get a virologic test for HIV within 2 months? Less than 0.2%. Okay, and when we look at mother-to-child transmission and it's modeled out, there are about 400 pregnant women in the Philippines with HIV last year. Okay, fewer than 10% of them were offered preventive therapy or treatment for their HIV, and it is estimated that 110 children last year were infected with HIV through maternal-to-child transmission. Every single one of those infections could have been prevented. So again, this is not to say, look out. This is to say, how can we harness the energy of the PIDSP to make sure this doesn't happen anymore? So again, bad graphics, but the point here was just looking at the actual number of children that have been treated in the Philippines for HIV. In 2007, there were 3 children. Okay, in 2013, there were 17 children. That's it. Okay, these numbers are really alarming in terms of the huge gap they suggest between the number of children in need of treatment and the number of children who get treatment. The good news is that there are multiple areas in which we can intervene in pediatric HIV, both in terms of the affected population, in terms of prevention, diagnosis, treatment, and family-centered care. I would point out that children are at risk for HIV even if they themselves are not infected, and that their parents tend to die of HIV. Okay, so I'm not saying of all the street children or the homeless children in the Philippines have a parent with HIV or who died of HIV, but even if the kids aren't infected, they're at very high risk of having their lives very disrupted by this disease. Okay, even among children, so if a child is born to a woman with HIV, there's a third of those children will be infected with HIV, okay? They're infected in utero, they're infected during delivery, and they're infected with breastfeeding. So if you have 400 pregnant women, you probably have 125 kids with HIV. Okay, but you have another 275 children who were exposed but not infected. And what we know from several large studies that have been done primarily in sub-Saharan Africa, even if the children themselves are HIV negative, their immune systems do not function normally. Okay, they're not able to mount a normal antibody response, and multiple studies have found these children are at much higher risk of other infectious diseases, including the typical HIV-defining illnesses, tuberculosis, pneumocystis pneumonia, and CMV. These kids also die at a rate anywhere between 5 and 10 times higher the population of normal children. So we're going to talk a lot today about the kids who are infected, but I just want you to be aware that the children who are born to women with HIV who are uninfected also face significant morbidity and mortality risks and should be monitored closely. So I want to talk a little bit about HIV prevention. You know, there's a lot of stuff that goes on in talking about HIV as a preventable disease, and we should focus all our resources on preventing HIV as opposed to treating HIV. We know that's a false dichotomy. Okay, we know treatment for HIV is preventing HIV because when people are on HIV therapy, their viral load is decreased and they're much less likely to transmit disease. When we used to think about preventing maternal-to-child transmission, unfortunately, the global response was to try to get away with as little as we could, to try to get away with as little cost as we could. And so instead of advocating triple therapy for women of childbearing age or women who are pregnant, which is a life-saving intervention for them, we did strange things like recommending AZT during labor, or recommending single-dose Nevirapine for women during pregnancy. While these were important in decreasing the burden of disease among children, they were a disaster for women in that using a single drug in HIV is a recipe for creating resistance to that drug. And unfortunately, that's what happened when single-dose Nevirapine was widely recommended around the world. And there's some really interesting data from Thailand that showed that women who got single-dose Nevirapine to prevent the transmission of HIV to their children, they themselves rapidly became resistant to Nevirapine and were not able to achieve virologic suppression when they were eventually on antiretroviral therapy themselves. So we'll talk in a minute about regimens, but the other problem with women and prevention of HIV, when you talk to women who either have HIV or are at risk for HIV, and you ask them what their experience has been with the healthcare system, they tell you this: nobody cares about me, they only care about my unborn child. Okay, and it's kind of true when you look at HIV prevention. These women feel like they're just a baby factory, and the only reason anyone is talking to them is just to focus on the baby. And while I agree that child is precious and should be prized, women do much better if we pay attention to them throughout their lives and throughout the whole entire reproductive cycle. So I'm telling you guys some bad lessons we learned globally, so I hope you won't make the same mistakes here in the Philippines. So our recommendation is that all pregnant women should be offered an HIV test during every pregnancy, okay? And if that test comes back positive, that woman should immediately be offered triple therapy, both for her own health and to reduce the risk of transmission to her child. Now, I realize I should probably be talking to a room of OB and gynecology folks, because you guys don't generally see the pregnant mothers. But again, this is a great advocacy point, and I know you guys are fierce advocates because I've seen it and felt it since last year, but very much in the rooms over the last couple of days. All pregnant women should be offered an HIV test with every single pregnancy. Because if they got pregnant, they have a risk factor for having HIV, right? They're clearly having unprotected sex. Now, a lot of times in low-burden countries, they say this isn't cost-effective, we don't have that much HIV. I can tell you in the United States, HIV transmission from mother to child is below 1%, and it's below 1% because we test every pregnant woman for HIV every single time she's pregnant. This saves lives. It will be the one way you can virtually eliminate pediatric HIV in your country, and I highly recommend you talk with your colleagues in OB about this. So if the woman comes during labor and hasn't had any prenatal care, or she hasn't been able to access, sorry, my clock was going down. If she hasn't been able to access antiretroviral therapy, she should be offered an AZT-based regimen with Nevirapine during labor and delivery, okay? But just recognize that when you give a woman something less than triple therapy, you're putting her at risk for later failure, and that child at risk for becoming an orphan. So what do we do if we have a baby who's born to a woman with HIV? So again, the best prevention of transmission from a woman to a child is triple therapy for the mother as soon as possible. If it's not possible, or the woman finds out she has HIV during labor and delivery and she gets no preventive therapy, you need to give the baby preventive therapy. Okay, and what we recommend for babies and what the Philippine HIV guidelines recommend is that they get Nevirapine every single day for 6 to 12 weeks. Particularly if that mother's gonna breastfeed, this child needs some form of prophylaxis. Nevirapine has been shown to be better than AZT in preventing maternal to child transmission and in prophylaxing children after they've been born. So it's either daily Nevirapine for 6 to 12 weeks or twice daily AZT. In terms of feeding, it's a little bit of a dilemma, and it was a big dilemma we faced in the southern African countries. Breastfeeding is best for children, and we know that. They get maternal antibodies, life is good. But if that mother has HIV and she's not virologically suppressed, breastfeeding can be a very dangerous and risky behavior. And in fact, we know of all children who acquire HIV infection from their mothers, 1/3 of them acquire it during breastfeeding, okay? So it's important to think about and develop some principles, because you guys will be asked about these questions. You're the ones who promote breastfeeding, and you're the ones who promote the ideal way to feed a child. If you have an HIV positive mother, the worst thing she can do is mix breast and bottle feeding. Okay, that's the absolute worst thing that can happen. If she's gonna breastfeed, she needs to do it exclusively. If she's gonna formula feed, she needs to do that exclusively. We used to advocate very strongly for formula feeding in infants that were born to women with HIV infection. It definitely decreased the risk of HIV transmission, but what we found in a lot of countries is that these children were dying of pneumonia and diarrheal disease. So in fact, the mortality from HIV went down, but the mortality from pneumonia and diarrhea went up. And so the overall improvement in mortality with formula feeding, there wasn't one. The children were still dying, they were just dying of something else. What we do know is best, actually, is to encourage breastfeeding if the mother is on triple antiretroviral therapy. So again, if we can put her on triple therapy, suppress her viral load, then there's very little virus in the breast milk to infect the child. So this is another reason why women with HIV need to be offered triple therapy. Okay, and a lot of this work comes out of a large study that was done called the MASHI study in Botswana. You know, if the woman has access to clean water and formula, it's reasonable for her to formula feed. But again, you want to be careful that you're not trading one cause of mortality for another. So how do we diagnose HIV in children, either newborn children when we know their mother is HIV infected, or in other age groups? So again, I will sound like a broken record, but all women who are pregnant should undergo HIV testing with every single pregnancy. Children that are born to women with known or suspected HIV should be offered a virologic test. So many of you know our current testing methods for HIV in adults and in older children relies upon an antibody. If we test, for an antibody in younger children, they often have the maternal antibody already present. So in a child who's born to an HIV-infected woman, if you look for an antibody, you may find it, whether or not that child actually has HIV. So we recommend in younger children doing a virologic test. So you do a viral load or another virologic test if the kid is younger than 18 months of age. Okay? Ideally, you'd like to test the child prior to initiating Nevirapine preventive therapy, because if the child has HIV and you give them Nevirapine, you're at risk for generating resistance. Practically, this isn't possible because the child has to be 6 weeks before you can do a virologic test, and by that point, they should have already been placed on Nevirapine therapy. So if you have a child who's born to an HIV-infected woman, she was not on triple therapy, you give the kid Nevirapine for 4 to 6 weeks, and then you do a virologic test. Okay. But not all children with HIV were infected through maternal to child transmission. Blood transfusion transmission is very, very low. What we see sometimes, however, in our adolescents, even our young adolescents, and I mean, again, check out Dr. Mendoza's poster out there about STDs in 10-year-olds. It does happen. So, you know, we need to think about transmission from a parent. We need to think about transmission through sexual contact or blood or other bodily fluids. But when should you suspect HIV? You have a kid you're seeing in your clinic. Mom may or may not have HIV. You don't know. These are the risk factors, and these are things that should make you think about ruling out HIV in a kid. Are one or both of the parents dead? Okay, dead parents usually mean something bad happened. In a lot of places, that something bad is HIV. If you have a kid who's failing to thrive, this is another situation in which to think about HIV. It's always good just to rule it out, get it off the table, and an HIV test is relatively straightforward to do. Children with repeated bacteriologic infections need HIV diagnosis. Children with TB should undergo HIV testing. Other rare infections, severe rashes, kids who are born to sick parents, and then again in older children or adolescents, think about sexual exposure and assess them for other STDs. I just want to mention in small babies, the method for testing accepted around the world is using a dried blood spot technique. It's a very efficient way to perform virologic testing in children. You basically do a heel stick, and then you collect 5 drops of blood on a special card. You can either have that blood evaluated in your laboratories here in the Philippines if they're able to do it. What we used to do in Southern Africa, because no one could do viral load for us, is you can pack these in an envelope and ship them anywhere. So it's a very efficient way to do HIV testing on very small babies. In terms of treatment, what are the kids or what are the indications for treatment in a child who you know has HIV? Any child under the age of 5 years of age with HIV should be treated regardless of their CD4 count. Okay, we used to say look at the CD4 count, or in younger children especially the percentage of CD4 cells as an indicator for when the child should be started on HIV therapy. We now say if that kid is under 5 years of age, they need to be started on ART regardless of CD4 count. If you have a child who's over the age of 5 and they have a CD4 count that's less than 500 or a WHO stage 3 or 4 condition, and this includes tuberculosis, they should also be started on antiretroviral therapy. We know that an earlier initiation of antiretroviral therapy is associated with better outcomes. The problem in children is that you're often looking at lifelong therapy for them. So some people try to delay the initiation because they're worried about adherence. I can tell you, I have patients who were born with HIV who are in their 20s now. And it's lovely to see. It's such a gift. And they're fine. They've taken these medications all their lives, so they're very adherent. Adolescence is a little bit of a tough period. But the sooner you start kids on therapy, the better the outcomes. What are the recommended regimens for treating children with HIV? HIV, we always use 3 drugs. Okay, triple therapy, highly active antiretroviral therapy, you use 3 drugs. There have been studies that have looked at 3 versus 4, no benefit with 4 versus 3, so a minimum of 3 drugs, and we usually use 2 drugs from a family called the nucleotide reverse transcriptase inhibitors and the nucleoside reverse transcriptase inhibitors, and then 1 drug either from the protease inhibitors or the non-nucleoside reverse transcriptase inhibitors, and now we also have the integrase inhibitors. But we like to use alphabet language in HIV treatment. It's like alphabet soup, but in the Philippines it's relatively straightforward. If you have a child with HIV, you start them on a regimen of AZT, 3TC, and Nevirapine. Okay, that's what's available, and that's what you guys should do. This recommendation differs a little bit from international guidelines. And the one caveat is if you have a child who was exposed to Nevirapine or a mother who was exposed to Nevirapine, you should use a protease inhibitor instead, and that's usually the drug called lopinavir/ritonavir. These are the international recommendations. What international specialists suggest is that a kid who's younger than 3 years of age should get lopinavir/ritonavir instead of Nevirapine. Okay, AZT is a great drug. It can cause anemia and problems with thrombocytopenia, so you can use the drug called abacavir. In children over the age of 3, you could also use the drug tenofovir, and children over the age of 3 could get efavirenz instead of Nevirapine. These are things you can always look up. My fellows always get very agitated when trying to learn about HIV therapy. I tell them it's okay, you can look these things up. Okay, what you need to remember is triple therapy. Again, adolescents, they get the same treatment as adults, and the treatment recommended in the Philippines and globally is a tenofovir 3TC efavirenz regimen. Adolescents, sorry everyone, too much chattering. Adolescents need improved screening, and they need improved social support. You know, adolescence is such a tricky time, and it's a time when a lot of kids are exploring their sexuality. I grew up in a Catholic family, so you know these things were not talked about, and I know the Philippines is a very Catholic country. I promise you, the adolescents are having sex. It's just what they do. This is, you know, what adolescents get up to. So if they're known to have HIV, this is a tricky time for them while they explore their sexuality. If they don't have HIV, they're at risk of acquiring it, especially since they're kind of secretive about the fact that they're having sex. I know that discussing condom use is a tricky issue in a Catholic country. I will tell you that condoms save lives. So, you know, adolescents need help and support negotiating sexuality and staying on therapy. This is just another bad chart, bad graphic to show you remembering the dosing and the calculations and the tablets. There are many job aids that can help you. The one in the top is from South Africa. It's just a nice dosing chart, and the one on the bottom is a wheel that you can spin based on the weight of the child. Children who have HIV are at risk from certain vaccines, particularly live vaccines. So it's important that they be administered vaccines, but that they be given vaccines on an alternate schedule. Again, these lectures will be made available to you guys, but this is the vaccination schedule that's recommended for children with HIV. You can see that the MMR is delayed, so the measles, mumps, rubella, largely because it's a live virus. Okay, I just want to quickly mention some psychosocial considerations in the management of children with HIV infection. The first is, when do you tell them, right? You have a child who was born to a mother, and if they're living in the Philippines, most of them were not offered prevention of maternal to child transmission, okay? This child is born with HIV. When do you tell that child? When do you say you have HIV? When do you start talking about it? Nobody knows the right answer. I can tell you that kids with chronic illnesses are far more aware of them than we think they are as adults. And many of us recommend including the child in the therapeutic plan and talking about his or her disease as young as possible. Okay, we talk about reducing stigma, but when we don't talk about HIV as providers, we're perpetuating stigma. So there's really no harm in telling a child they have HIV. That's the name of their disease. If they take their medicine, they'll stay strong and healthy. But these, again, are kids who are going to live with HIV for the rest of their lives. And it's a really exciting development, but none of us are sure how best to counsel them. A lot of these adolescents and young adults will want to have families, and that's very appropriate. They should have families, and they can if they're properly provided with antiretroviral therapy. Sexuality is always an issue, and then stigma, as I mentioned, is a serious problem. I just want to mention, in terms of pediatric HIV treatment, we do have child-friendly formulations. Unlike for TB and multi-drug resistant TB, where we're constantly begging people for this, the HIV community is far more advanced. There are fixed dose combinations that are available in dispersible tablets, in syrups, and then they have these sprinkles, actually, that look like a nice candy that you sprinkle on top of food or other ice cream, other treats, and the children can take them. I'm going to skip that slide. So again, I just want to mention the family-centered approach to HIV. We tend to forget about a family-centered approach because we think about the classic risk groups for HIV. We don't tend to think of them as being very family-oriented. Okay, men who have sex with men, not usually in a family way, but that's changing. Commercial sex workers, we tend not to think of them as mothers, when in fact most commercial sex workers actually are mothers. Okay, so we need to engage them as we would engage mothers. And I promise you guys, based on trends seen in other countries, with the rising rates of HIV you're seeing here, you're soon going to be seeing much more HIV with heterosexual transmission as the only risk factor. In the United States, we have a very similar epidemiology to what you guys have here. The fastest growing group that's becoming infected with HIV are young women who are in minority groups. Okay, and these rates are going through the roof. So just be aware of that. I will tell you that successful approaches to treating children always include having their family networks as part of the treatment plan, whether that's grandma, whether that's an orphanage, or whether that's mom who's sick herself, or dad who's sick, or brothers and sisters. Children always do better when we involve their families, and we tend to forget about that with HIV because a lot of us don't like their families. Mom's a commercial sex worker, dad's an alcoholic, grandma takes care of them, they're in and out, their lives are in chaos. So we tend to think of the families as bad people who gave these kids HIV, when in fact it's not the case. They're struggling with life the same way all of us struggle with life. Where we're failing them is by not appropriately preventing the transmission of disease to these kids. 8%. And the Philippines is a stellar country in terms of your health achievements. I was actually shocked to see that 8% of women with HIV are actually offered preventive therapy. And this can be changed quickly. I want to be like Dr. Sally and say by 2017, 100% of pregnant women should be offered antiretroviral therapy, and all pregnant women in the Philippines should be screened for HIV. You will eliminate the problem of pediatric HIV in this country, except among your kids who are already infected, who are going to live long, healthy lives. So that was actually my next slide, is you're a low burden setting here. There is no reason any child should get perinatal HIV infection in the Philippines, no reason whatsoever. And there are really multiple areas where we can make this happen. Talk to your friends who are obese, bother them, encourage them to test all their pregnant women. Sometimes people will say it's too expensive to do an HIV test on all the pregnant women in the Philippines. I will tell you the cost of HIV testing for every single pregnant woman in this country is far lower than the cost of providing a child with lifelong antiretroviral therapy, is far lower than the psychological cost of having a child infected with HIV. It's completely unnecessary. So I think with broad access to diagnosis and treatment and family-centered care, kids in this country are not going to have to worry about HIV anymore. And that's the end of my talk. So thank you for listening so politely to all 3 of my lectures and for having me here.